tissues at the foramina. When you look at the spinal cord in flexion now, there's a upward pulling occurring in the spinal cord and downward pulling occurring. And here you have a torsion in the spinal cord. It alters the perivascular clefts, causes an ischemia in the cord. The ischemia in the cord puts the body into defense. When it's defense, you have stress hormones actually hitting the frontal lobe of the cortex. As a result of that, the person cannot have executive functions, really cannot organize their life effectively, and is into defense. What happens is there's actually an inflammatory process that occurs when you stretch the spinal cord, and that inflammatory process is actually associated with literally an itchy brain, which actually causes aberrant subluxated, as you may say, function between innate and educated mind. So we see this picture here. Now, what's really important to know is that, especially in basic care network in level 1, we're looking to see that the connective tissue in the spine is able to start self-organizing, has more energy, as the bioenergetic intelligence is able to self-regulate along with the emotional energetic intelligence. And what happens is you start having a shift of the connective tissue around the brain and spinal cord. And in level 2B, where we deal with the transform aspect, we have the wave go through the spinal system and more through the spinal cord and nervous system directly, and you're going to also have the self-regulation of the flexion extension patterns, and it could be actually go towards a resolution of that. When you take a look at the effects of flexion extension of the spinal cord, the next set of pictures show you basically tethering that's occurring in the lower spinal cord. The following slide are the effects of lateral bending of the spinal cord, and you see the same type of lateral bending distortion, both in the person's antalgic posture, and also looking at this, you see the actual stretching of the spinal cord in a lateral component. Brigg continues. The spinal canal undergoes considerable changes in length between the extremes of flexion and extension, particularly in the cervical lumbar regions. The total change is the order of 5 to 7 centimeters, maybe about 2 or 3 inches, and is greater on the posterior than the anterior aspects. Similarly, on lateral flexion, the canal is lengthened on the convex side and shortened on the concave. So chiropractors usually tend to think of the vertebra as moving and the spinal cord as fixed, but realize every tissue of the body is moving. Even the connective tissue of the body is in an oscillation of movement, and the oscillation of the tissues is a communication itself within the system. So what happens is when you start having an alteration in the spinal cord motion, you have tension being transmitted. At its cranial extremity, the spinal dura mater is attached to the circumference of the frame and magnum, and its caudal end, it's anchored to the coccyx by the filum terminality. You'll soon see a picture from Stevens' textbook of the spinal cord tension in both directions. When the trunk is fully flexed, the dura is under tension, as is also the cord, and stretching occurs. Part of this tension is transmitted from the dura mater by the dentate ligaments to the pia mater. But by far the larger component of the tension is set up directly in the cord by virtue of its anchorage to the two extremities, the brainstem and corda equina. This is where a postural analysis, especially computerized visual assessment of posture, is really, really important, because it's also telling you about the distance of the spinal cord, and it's telling you about the potential mechanical tension in the spine. Now we get to something a little bit more exciting here. The other is exciting also because you're actually seeing a Stevenson picture where you actually see stretched meningeal sac, coccyx subluxated to anterior, producing spinal cord tension above. And you actually see where the spinal cord is in actually wrong position as it's being pulled up, with impingements in actually even the sacral foramina. And you see what that looks like, extension and flexion, in the actual post-mortem. The next picture, you see Stevenson's textbook, where it actually shows schemes of cord pressures, cord tensions, and multiple pressures. And it shows here a picture of an instance on the right where the meninges attached to cervical vertebra, and then spinal cord tension pattern, and you actually get to see the meninges actually affecting the axis vertebra, and how it actually tractions the cord here, both anteriorly and starts pulling it superiorly. You then see the cord going through the neural canal, and a diagram of the cord pressure there. And then the picture you're seeing next to it is normal and under tension, the ligament denticulata tension possibilities. What you're seeing here, it was 50 years before Alf Brigg's work. Now, the magnitude of the tension, according to Brigg, in the cord depends firstly on the anatomical factor of body posture, which determines the relative length of the spinal cord and the canal. We just discussed that. The total tension induced may well lead to neural dysfunction, and the involved nerve fibers in the cord and nerve roots may be said to be overstretched. The most significant consequence of overstretching nerve fibers is impairment of their conductivity. Now, Brigg also says that within minutes of a stretching of the